In this video, we're going to talk about emphysema. And when we look at emphysema, we're really looking at two things. So if we draw in our bronchioles here, so if we're looking at a normal airway, we have our bronchioles, our little terminal bronchioles that are then going to spread into our alveoli, where we have gas exchange occurring. So the terminal bronchioles as well as the alveoli will permit gas exchange. When we're looking at emphysema, what is happening is often due to chronic smoking or exposure to pollution, a patient is going to have a loss of bronchial tethering and hyperinflation of the alveoli. And this is happening at the distal bronchioles. So again, when we're looking at the terminal and respiratory bronchioles as well as the alveoli, this is typically where we're seeing that happening. So if we draw this in, what we start to see is our bronchioles are collapsing, or we have a loss of bronchial tethering. So we can see here that those bronchioles are no longer inflated or have good elasticity, so they're falling in on themselves, and we get hyperinflation of the alveoli. So when we're looking at emphysema, we're really looking at two particular things. We're looking at hyperinflation of alveoli. So you can see compared to our normal alveoli here, we have these big distended alveoli. And we have a loss of bronchial tethering, which equates typically to bronchial collapse. So again, big thing here we have is a loss of our bronchial tethering. So that means that basically the elasticity or the mechanism in which the bronchioles are being pulled open has been lost. So we have a loss of bronchial tethering, and we have the second big thing is hyperinflation of the alveoli. So we're seeing that the alveoli are becoming large and distended. So hyperinflation of the alveoli are the two big things. Often when I'm talking about bronchial tethering, people are kind of confused about what that means. If you picture our bronchioles, so I'm going to just draw a little bronchial tree here with our alveoli, we have elastin that's going to help pull open our bronchioles. So one of the ways in which our bronchioles remain open is they are tethered to each other, or they have kind of this tethering that promotes the bronchioles to stay open. When we have something like emphysema, one of the things that happens is we lose this bronchial tethering, which is going to promote collapse of those bronchioles. You can picture those as kind of like little springs that are holding the bronchioles open. If we lose those springs, the integrity of the bronchial wall is lost, and we start to see a decrease in bronchial function. So when we look at loss of bronchial tethering, really what we're talking about is we lose one of the functional units or some of the functional units that are keeping those bronchioles opening, and that's often elastin that's helping do that. So we'll draw that in here as elastin. So when we look at emphysema, we're looking at collapse of the distal airway, so loss of bronchial tethering, which can lead to bronchial collapse, and hyperinflation of the alveoli. So let's take a look at how that normally happens. So our alveoli typically are made up by a number of different things. We're going to draw in some of the important ones to emphysema here. So we know that in our alveoli, we have lots of elastin. So picture these as being the cells of the alveoli where essentially we've blown up a large piece of our alveoli to take and look aside here. So we're looking at a cross section of, say, this piece of tissue here. So in a normal alveoli, what we see is lots of elastin. So this again is what's giving our alveoli the ability to expand, but also then contract. So the elastin is important for recoil of our alveoli. We also have other elements in here that are going to play a role. So we have what's called alpha-1 antitrypsin. So we have alpha-1 antitrypsin. And we have elastase. And elastase is an enzyme that is going to break down our elastin. And what's interesting about our alveoli is that alpha-1 antitrypsin and elastase have opposing functions. So the function of alpha-1 antitrypsin is to inhibit elastase. So alpha-1 antitrypsin is going to inhibit elastase function, or basically slows down the ability of elastase to do its job. And then elastase is going to be an enzyme that breaks down elastin. So if you think about it, this plays a role when we're looking at lung repair, if we have dysfunctional elastin or elastin that's no longer necessary, scarring, inflammation, elastase is going to come in and help with that repair. So elastase is an enzyme that breaks down elastin. And these two are going to play a role together in order to create homeostasis. So we break down elastin when necessary using elastase. Now, what happens when someone has emphysema is typically they have been exposed to a large amount of pollutant. In our case, most often what we're seeing are patients are cigarette smokers. So more often than not, when we're looking at someone who's experiencing emphysema, often that's going to be a patient who has been a long-term smoker. So we draw a little cigarette in here. And the problem with cigarettes are the chemicals that are in cigarettes can lead to a number of different things that can cause problems for patients' lungs, especially when we look at cigarette use over a really long time. So one of the things that we need to be aware of is that smoking is going to lead to oxidative stress. So smoking alone or smoking cigarettes, one of the consequences of that is that this cigarette smoke is going to put oxidative stress onto the cells of our bronchioles and alveoli. So we see oxidative stress. And the problem with oxidative stress is that is going to promote the release of free radicals, or reactive oxygen species. I'm just going to draw those in here as an RO. So we've got reactive oxygen species. And as those reactive oxygen species are released, what they start to do is damage the endothelium, or we start to see damage to our cells. So as we have the release of these reactive oxygen species, we start to see damage to our bronchioles and our alveoli. And when we damage lung tissue, we stimulate an immune response. So one of the consequences of this damage, or one of the things that's going to happen as we are constantly smoking, having oxidative stress, and the release of reactive oxygen species, is that these reactive oxygen species will damage the endothelium, and this damage will promote an immune response. So the immune system is going to recognize, hey, something's going on here. My tissues are damaged. I need to do something about that. So we get an immune response. And with that immune response, what we start to see is recruitment of neutrophils. So we'll draw those in green. So what's going to happen with this immune response is we typically see recruitment of a large amount of neutrophils to the lungs. So neutrophils are going to start infiltrating the lung tissue. So with chronic smoking, we start to see our lung tissues being characterized by a lot of damage and a lot of neutrophil release. So these neutrophils are being stimulated by the immune response to be recruited to the area, and they're going to essentially infiltrate the area. The problem with neutrophils is that neutrophils decrease the amount, or essentially they're going to increase, the amount of elastase that's being produced. So neutrophil infiltration is going to be related to an increase in elastase. We drew elastase in purple before, so we'll continue with that. So what we start to see with those neutrophils being recruited is we start to make a large amount of elastase. So now not only is the lung being characterized by a lot of neutrophils, which is going to cause inflammation, we start to see a large amount of elastase going to the area. And we know that elastase performs a couple different functions. It's going to break down elastin, and it's going to damage our bronchioles, or it leads to a loss of bronchial tethering. So we start to see a huge amount of elastase entering the lungs themselves. So we have elastase beginning to increase production in the tissues of our lungs. Smoking does a couple of other things that we need to be aware of. So when we look at this lung tissue compared to this lung tissue, smoking actually decreases the amount of alpha-1 antitrypsin available. So with smoking, we start to see a decrease in alpha-1 antitrypsin. And what that means is that our elastase can work uninhibited. We knew that alpha-1 antitrypsin was there previously to downregulate or decrease the function of elastase so that we can maintain homeostasis. In this case, that's not happening. Smoking is going to decrease the amount of alpha-1 antitrypsin available, and it's going to lead to elastase being able to work essentially uninhibited. So not only will we have more neutrophils, which means more elastase and more damage to our lung tissues, we also are going to have less ability to decrease the function of elastase, so it can work uninhibited and cause lots and lots of damage. The other problem, there's two other problems that go along with smoking. Is smoking, especially the nicotine in smoking, is going to promote the neutrophil recruitment. So nicotine has a chemotaxic effect on neutrophils. So what we start to see is nicotine promotes chemotaxis in neutrophils, or makes neutrophils want to come to the area even more. So smoking will have a chemotaxic or an attractive effect on neutrophils. And it's going to make more neutrophils come to the area. So we start to see, again, more neutrophils, and we know that more neutrophils means more elastase. More elastase means we're going to break down more elastin, which is the core problem here that causes this hyperinflation and loss of bronchial tethering. Finally, the last thing that we see smoking doing is cigarette smoke is going to trigger histamine release, which will cause bronchoconstriction. So smoking will also lead to some bronchoconstriction, especially when I'm smoking that cigarette, promotes the release of histamine and can cause some bronchoconstriction. So what we'll do is we'll break this down into a flowchart so it makes a little bit more sense before we start talking about the signs and symptoms that we actually will see. So when we talk about emphysema and we look at making a flowchart for how this process kind of unfolds, the big thing that we're going to be looking at is smoking. Emphysema can happen in patients who are exposed to high levels of pollution. For our subset of the population, typically what we're going to see is smoking being the primary cause. And the problem with smoking is that it is going to lead to oxidative stress. So with excessive smoking, we see an increase in oxidative stress. And with that oxidative stress is going to come the production or the formation of free radicals. The problem with these free radicals is that those are what are going to start damaging the endothelium. So when I smoke a cigarette, I have oxidative stress, the formation of free radicals, and it's those free radicals that start to cause destruction of the lung endothelium. So we start to see destruction of the endothelium. As the endothelium becomes destroyed, just like any damage that we have to tissue, an immune response is going to occur in order to try to have that reparative function. Problem is that this is chronic smoking or long-term smoking, and the immune system wasn't designed to basically be bombarded in the lungs by these free radicals and the destruction of the endothelium. So we see kind of a chronic immune response. So we start to see the immune response is activated. And again, we're not talking about one cigarette here. We're talking about this occurring over an extensive period of time. This immune response is going to lead to the recruitment of neutrophils. So we start to see recruitment of neutrophils to the area. So we get recruitment of neutrophils. And as we mentioned before, the challenge with neutrophils is that they are going to promote the formation of elastase. So as we have more neutrophils and the more neutrophils that come to an area, we start to see an increased production of elastase. So with an increase in neutrophils, we start to see increased production of elastase, which we know is going to break down elastin. So we start to see a breakdown of elastin because of these. So we start to get breakdown of elastin, and we start to lose the amount of elastin that is in the lungs. Again, elastin is going to be important because it plays a role in bronchial tethering. It provides a role in alveolar recoil. So without it, those two things can't happen appropriately. Now, it's not just the production of free radicals and oxidative stress that plays a role here. When we see someone who's smoking regularly, we know that there's going to be an increase in nicotine. And the problem with nicotine is that it has a chemotaxic effect on neutrophils. So nicotine will perform the role of chemotaxis, which really is just essentially recruitment. So that chemotaxis not only is going to help. Not only are we going to see increased neutrophils created, but with chemotaxis, they're almost signaling those neutrophils to come to the lung. So we get even more recruitment of neutrophils to the alveolar tissue or to the endothelium because this nicotine is promoting that or saying, hey, come here, we want more neutrophils in this area. The other problem that exists with smoking is that we're going to see oxidative stress, and that oxidative stress is going to lead to a decrease in alpha-1 antitrypsin function. So as we have oxidative stress, we decrease the function of alpha-1 antitrypsin, and just like we talked about before, the role of alpha-1 antitrypsin is to decrease elastin function. So we start to see inhibition of elastase. So normally, alpha-1 antitrypsin is going to allow, or is going to provide a homeostatic mechanism in decreasing elastase function. Well, if I have less alpha-1 antitrypsin, then I am going to basically not be able to inhibit that elastase. So I'll see it able to have an increased production and function. This is where genetics can play a role here as well. So patients can actually have a genetic dysfunction that leads to a lack of alpha-1 antitrypsin. So that can be one of the causes of emphysema. In these patients, we're actually going to see emphysema occurring at a younger age than someone who's been smoking for 30 or 40 years. What we'll do now is take this flowchart and link it to the signs and symptoms of what is actually happening when I have a breakdown of elastin and I lose bronchial tethering and have alveolar hyperinflation. So the problem with emphysema really centers around this decrease or this destruction of elastin. And two core problems exist with this. So one of the things that we're going to see is we have this destruction of elastin is that we are going to lose the elastic recoil of the alveoli. So if we have destruction of elastin, we start to see decreased elastic recoil of the alveoli, where that elastin is really what's allowing the alveoli to inflate and then recoil or contract. Picture an elastic band that gets expanded. It wants to snap back into its shape. Elastin is what's allowing the alveoli to snap back into its shape. So when we have destruction of elastin, one of the things that we see is decreased recoil of our alveoli. And one of the challenges with that is that it leads to hyperinflation, or alveoli do not want to de-inflate and go back to their normal shape. So we start to see hyperinflation of our alveoli. The other issue that exists is, remember we talked about that bronchial tethering. So if I have my bronchioles, and this is kind of the normal setting with some elastin that's going to provide the bronchial tethering. When I lose this bronchial tethering or it doesn't exist, one of the consequences to the patient is that they will no longer be able to keep their bronchioles open as well. So with the decrease in elastin, we also see a decrease in bronchial tethering. And that increase in bronchial tethering can lead to collapse of our bronchioles, especially on expiration. This can lead to collapse of our bronchioles. So a couple of things happening here, and especially if we kind of take a look at what we're seeing now, is I have a bronchiole that's lost its tethering. So we'll draw that bronchiole in here. It has lost some of its integrity and is prone to collapse. So any pressure that we put on this bronchiole can lead to collapse of it. We have an alveoli that's lost its integrity and is prone to hyperinflation. So we can start to see hyperinflation of this alveoli. So again, loss of bronchial tethering here and hyperinflation of the alveoli here. So think about what happens as someone inspires. So I'll draw inspiration in bright blue here. So we're looking at inspiration. On inspiration, we have air coming in to the bronchioles and filling the alveoli. And we'll have the alveoli are going to expand. The loss of bronchial tethering is not typically a problem on inspiration. As air is being forced in, that's going to help kind of stent those bronchioles open. And we see that the alveoli will inflate. So we see kind of big inflation of the alveoli. Now, if I draw in orange here, what happens on expiration, what we're going to start to see is When I expire, I see increased pressure, intrathoracic pressure. So think about as we expire, we have increased force on the lungs, or we're basically decreasing the space in the thoracic, or decreasing the thoracic space, which will increase pressure. And as I increase that pressure, if my bronchioles have lost tethering and their integrity, they're more prone to collapse. So on expiration, our bronchioles tend to collapse in on each other. The problem that we have here is I still have air that's trying to escape. Remember, I have this big hyperinflated alveoli. And the issue that exists is because those bronchioles have collapsed, all of that air that's trying to leave on expiration can't do so and stays within the alveoli. So if we think about what happens, or what does that look like as the patient continues to inspire and expire, and we can kind of draw a progression in here, is we'll have inspiration where the alveoli will inflate. We have expiration where that air can't get out. We have another inspiration where now more air fills. We have another expiration where more air can't escape. And you can see the process here is that we're going to continue to hyperinflate these alveoli until we have some significant consequences. And this is what we call air trapping. So we have air that gets trapped in the alveoli, and that is the consequences of these two things together. The collapse of the bronchioles and the hyperinflation of our alveoli are going to promote air trapping. And again, we see this a lot on expiration as pressure within the chest wall increases. And this is how we start to see a number of the signs and symptoms that go along with emphysema. And that's where we'll go next, is to talk about, well, what are these signs and symptoms and why do they occur? So what are the core consequences of emphysema? So again, as a recap, we're really looking at two big problems here. One is that we have our hyperinflation of the alveoli. So we have hyperinflation of the alveoli that allows them to become big and distended. And the other kind of core issue that is going to exist here is the loss of bronchial tethering, or the ability of the bronchioles to now collapse more easily. So we have that loss of bronchial tethering. And we know the problem with these two things together is that the alveoli are going to be prone to air trapping. So air can't get out on expiration. So if you think about what's happening here, we start to see a huge amount of air getting trapped into the lungs because the alveoli are able to hyperinflate. So the alveoli can get way bigger. They don't like to recoil as much as they normally do. And the bronchioles are collapsing, which is not allowing that air to escape. So we can get this kind of chronic air trapping, or this chronic hyperinflation of the alveoli. And one of the symptoms that we often see, or that is common in the emphysemic patient as a result of this, is a barrel chest. So if we think about emphysema, we can see this barrel-chested appearance. And again, that's because what's happening is the patient has a lot more air in their lungs than they typically would. So if you picture taking a big inspiration, this patient has a barrel chest because their alveoli are hyperinflated, which is pushing the chest wall up. You actually will start to see flattening of the intercostal angles. The patient is going to have that consistent barrel chesting, or opening of the chest, and hyperinflation of the alveoli. So two things we have to see going hand in hand for this patient are barrel chest, and we actually will see a flattening of the intercostal angle. And these two things together are going to be related to the fact that we have air trapping. So we have air trapping, which leads to hyperinflation of the alveoli. So air trapping and hyperinflation of the alveoli can lead to a patient having barrel chest and flattening of the intercostal angle. One of the other common symptoms you'll see in the emphysemic patient is they will have pursed lip breathing. So the patient will start breathing through pursed lips. And the reason for this is that pursed lip breathing provides a bit of negative pressure. It's going to provide a bit of positive pressure to the patient in order to open up their alveoli. So if we think about what's happening on expiration, let's draw again our alveoli on expiration in here again. We know they're prone to collapse. So on expiration, what's happening is I have an increase in intrathoracic pressure that's going to collapse my bronchiole. So Let's put that here. We have expiration. On expiration, we start to see an increase in intrathoracic pressure, or the pressure that's pushing on the lungs and subsequently pushing on the bronchioles and the alveoli, which will increase bronchial collapse. And that's because they've lost that tethering. So the bronchiole is not going to be able to stay open as well if it has no tethering. So remember, we typically have some bronchial tethering present, which would help keep them open. With the loss of elastin and the destruction of the lung tissues, we've lost that bronchial tethering. So we have an increase in bronchial collapse. What that means, or that increase in bronchial collapse on expiration, specifically what that means, if we pair these two things together, the patient's trying to expire air, but the bronchioles are collapsing on expiration. What's going to happen is air cannot escape. So air that's trying to escape cannot escape. So what we're going to see is air cannot escape, and we get air trapping. Again, when this happens chronically, we start to see things like barrel chest and flattening of the intercostal angle. So the patient will try to compensate for this, and they'll try to use some techniques to compensate for this. So what happens is when a patient will start to breathe through pursed lips, and what happens when a patient breathes through pursed lips is they're not going to be exhaling the same amount of air as they would be if they were not breathing through pursed lips. So we'll say that this is kind of the mouth when the patient is breathing normally. So there's our kind of normal breathing through the mouth. And in the pink here, we'll draw someone who's breathing through pursed lips. So obviously have a smaller opening with pursed lips. If we look at airflow through the up the airway and out of the mouth when someone is not breathing through pursed lips, so is breathing normally, so out of the nose or the mouth, we see clear laminar flow of air, and that air is going to move outward. So we see consistent outward movement of air, which is not going to lead to some huge pressure changes behind the mouth. Now, what happens when someone breathes through pursed lips? So let's take the open mouth out of the equation, and we have someone who's breathing through pursed lips. We're still going to be pushing the same amount of air up to the airway, but this air cannot escape, and we start to see some of that air wanting to move further back. So again, we'll kind of show the air that can escape. So if I'm looking at air that can escape the lungs, it's going to come up through the pursed lips and it's going to exit. But we're going to have that other volume of air that's trying to escape that is kind of smacking against the pursed lips and is going to move back into the patient's airway. And what's going to happen as we have that air that can't escape, so is kind of moving against the pursed lips, it starts to move backwards. And the benefit of this is that it stents the alveoli open, so or stents the bronchioles open. So that air that's traveling backwards, or that pressure that's building behind the pursed lips, so picture pressure building behind. Same thing is happening if I'm trying to, say I'm using a garden hose and I put my finger over the opening of the garden hose. Pressure builds behind that hose because I'm blocking the exit. So if you picture like the cartoon version of this, I put my hand over it, the hose expands. Well, picture that same pressure being applied to the alveoli. I'm breathing through pursed lips, so I'm decreasing the opening in which air can escape, and as a result, I'm going to build pressure behind it. The benefit of that pressure behind is that it's going to exert itself on the walls of the bronchiole, and we're going to see some ability to counteract the pressure that expiration, or the intrathoracic pressure on expiration, is exerting on those bronchioles. So it helps stent the bronchioles open. So when we look at pursed lip breathing, the function of pursed lip breathing is to stent open the bronchioles. So pursed lip breathing will lead to stenting of the bronchioles. So stent open the bronchioles. And the benefit of that is that we're hopefully going to be able to expire more. And one of the benefits of pursed lip breathing is it's also going to prolong the expiratory phase. So the patient should be able to breathe more out. So stents open the bronchioles to prevent air trapping, and it'll prolong the expiratory phase, which hopefully will allow for more air to exit the lungs and exit those alveoli. So it prolongs the expiratory phase as well. So we're hoping to stent open the bronchioles so the air can actually escape. So we're not seeing it totally collapse like this. We're opening them up or stenting them up a bit so the air can actually get out. And then prolonging the expiry phase is great because I got a lot of air that I need to get out of here. So if I prolong that expiratory phase, hopefully I can exhale more of this air and prevent some of this air trapping and hyperinflation that we see in patients who have emphysema. In emphysema, we also will see a few other things. These patients will typically present with hypertrophy of the respiratory muscles and cachexia of the other muscles, or basically loss of tone in the other muscles. That's because they spend so much time compensating. So as this patient, breathes and has accessory muscle use for a long period of time, you actually can see those muscles fatiguing or becoming hypertrophied because they are being worked so much. So you can see hypertrophy of the respiratory muscles, and we actually can see atrophy of the other muscles. So the patient may present with hypertrophy of the respiratory muscles, but atrophy of our other muscles. And the problem that we have is that if the patient is using their respiratory muscles so much, they're demanding a lot of their oxygen. But if the patient can't provide a lot of oxygen, then one of the problems is that the muscles will become atrophied. So a lot of the usable oxygen nutrients will be going to the respiratory muscles, while the other muscles will be neglected. So you start to see atrophy of the other muscles. And this is where you'll get that characteristic kind of pink puffer look. So the patient has atrophy of their muscles. They become really cachexic, or they lose a lot of muscle mass other than the respiratory muscles. They get these big respiratory muscles, this barrel chest and flattened intercostal angle, and then they're puffing because they're pursed lip breathing so much. What's important to recognize is that emphysema often goes hand in hand with chronic bronchitis, so it's very rare that we see someone who just presents with the emphysemic presentation. Emphysema and chronic bronchitis are both caused by smoking, so people who have COPD typically have a combination of those two phenotypes. There are a couple of other symptoms that we should talk about in terms of emphysema that go along specifically with emphysema. One of the other problems, or one of the other things that can cause this barrel chest or the flattening in the intercostal angle, is the formation of blebs or bullae. So the patient can develop either what's called a bleb or a bullae. And basically, these are just different terms for pockets of air that are going to form on the lung tissue. So if we picture the lung here, we know that we have hyperinflation. One of the problems is as the alveoli start to become damaged, we actually start to see destruction of some of the alveolar walls, which can allow air to, or basically air pockets to form. So as the alveolar wall gets really hyperinflated, picture an elastic band and I'm extending, the integrity of that tissue is going to be impaired. And as a result, one of the things that can happen is we can start destroying that tissue, and I get these pockets of air, or I have these kind of communications between my alveoli that allow air pockets to form. A bleb is when that patient has a pocket of air on the outside of the lung. So picture we have a lung here, and they have basically like a blister-like protrusion. So bleb would be kind of a air pocket that forms on the outer surface of the lung and looks more like a blister. So again, a bleb is essentially an air blister, or a blister-like protrusion that's happening on the surface of the lung. A bullae is an air pocket that forms within the actual lung tissue. So it's an air-filled cavity within the lung tissue. So for a bullae, what I want you to think about is actually a pocket of air within the lung tissue itself. So if I have my lung here, and I'll draw kind of two layers of tissue in here to make a little bit more sense, I got this pocket of air that exists within my lung tissue. So as my alveoli are forming together, I get an air pocket that forms. In either case, if you think about the consequence of this, or the problem associated with these air pockets forming, is that we're seeing that the alveoli are losing their integrity. And as those alveoli lose their integrity, that patient is going to be at high risk of rupture. So what can happen for these patients is eventually we can see rupture or barotrauma. And we know the consequence of that is going to be air can now leak into the pleural space, or into thoracic space. So rupture or barotrauma can lead to pneumothorax for these patients. And that's one of the life threats associated with emphysema, is that the patient's at high risk for pneumothorax once these blebs and bullae start to form. Some of the other things that we can see for the emphysemic patient is end-tidal CO2. You can see a shark fin pattern. So the patient may present with an increased end-tidal CO2. So the patient may present with an increase in CO2, so our levels may go up. And the patient may also present with a shark fin pattern. The reason for the shark fin kind of goes along with the pursed lip breathing is the patient is having a hard time expiring air. So if you think about your normal SpO2 reading, what's happening is we see expiration of our dead space gases, then we start to see expiration of our alveolar gases, and then the patient inspires. We have a nice normal kind of graph here as the patient has clear inspiratory period and clear expiratory period. The problem with someone who has emphysema is that they're going to be breathing through pursed lips. So the amount of air I can have exit my lungs at one time has decreased because I'm decreasing the opening in which it can leave, and I am having slower expiration. So what we end up seeing with these patients is you can see the shark fin pattern as they're trying to push the dead space gas out to even get to this plateau of where the alveolar gas is. And the problem is that we have to eventually inspire. So we have this kind of sharp inspiration as the patient exhausts their expiratory phase, which can lead to the shark fin pattern. So that's just telling you that we have decreased space through which we can exhale. So really this kind of prolongation or this shark fin pattern is showing us a couple of things. We're watching bronchial collapse here because we're seeing that the air has a smaller space to exit the alveoli. So we're seeing less of our alveolar gases making it out. We're also seeing a prolonged expiratory phase. So we're seeing that prolongation of the expiratory phase. And unfortunately, often not making it to all of those alveolar gases that we want. So then we get that kind of sharp inspiration as the patient is trying to get more air in. The other thing that this patient will have is often excessive shortness of breath on exertion. So one of the other big symptoms we see in patients with emphysema is that when they're at rest, they can compensate. They can use their pursed lip breathing to try and open up the lungs. The issue is that when I have things like blebs and bullae forming for this patient and I have this hyperinflation of the lungs, I've lost a lot of my functional residual capacity. So patients with emphysema have lost a ton of functional residual capacity. So they can't really compensate for exertion. Again, not as bad when they're at rest because they're using those compensatory mechanisms. But again, those are the compensatory mechanisms they would typically be using when they're trying to exert themselves. So they don't have the functional residual volume to support exertion. So we've seen a huge kind of decrease in their functional residual volume. So those are the kind of core signs that we see in someone who has emphysema. We know one of the big life threats here is pneumothorax. So the patient's at high risk of pneumothorax. The other big consequence that we can see for this patient is they are at risk of acidosis. So as the condition progresses, one of the other kind of key life threats that we should be considerate of is the fact that the patient is going to have a huge increase in carbon dioxide. So we can start to see high levels of carbon dioxide in this patient, which are going to lead to acidosis. So if we think about the problem with our respiratory acidosis is that this patient is seeing a large buildup of CO2. So they're having a hard time getting the CO2 out of their lungs. As that happens, they shift this equation to the right, or our bicarbonate buffer system to the right, and we're going to have a big increase in the amount of hydrogen ions that are going to be created. So the patient is at risk for a couple of different things. One is that we have an increase in hydrogen ions, and two, the patient has an increase in CO2. Both of these things obviously causing respiratory acidosis and the consequences of that. So the last thing I'd like to dive a little bit deeper into are the actual life threats of emphysema. So if we take a look at emphysema, there are three primary life threats that we can see. One is going to be related to that barotrauma that we talked about. So the patient is at risk of barotrauma, which can lead to mechanical shock state, specifically when we're looking at something like a tension pneumothorax. The other problems that exist reside around the VQ mismatch that is happening. So in this patient, we're going to see a VQ of less than 1, or their VQ will be less than 1, which puts them at risk of respiratory acidosis. So this VQ of less than 1 is going to first promote the retention of CO2 and lead to potentially respiratory acidosis. The other problem in the long term is that the patient is going to have a VQ of less than 1, which is going to promote hypoxic vasoconstriction and move the patient towards cor pulmonale. So the other problem is this VQ less than 1 can actually lead to cor pulmonale. So we talked a little bit about the problem with barotrauma, or how that can happen in these patients. So if we take a look at the lung tissue itself, one of the risks that are associated with emphysema is that the patient can form these blebs or bullae. And over time, as we continue to have this hyperinflation, and we'll draw kind of our lung in here as being this kind of big hyperinflated lung, one of the problems is eventually that lung tissue can become destroyed, or that bleb or bullae can actually pop, which will lead to air exiting into the pleural space. So if air can exit in, we can see this buildup of air in the pleural space, which puts the patient at risk of a mechanical shock state. So one of the consequences, or one of the things we need to be concerned about with emphysema, is that the patient is at risk of tension pneumothorax if their condition progresses. So emphysema can lead to tension pneumothorax. We know, again, the consequence of tension pneumothorax is going to be is that pressure builds in the thoracic space. It's going to eventually start shifting towards the unaffected side, which will put pressure on the mediastinum in the heart. And you can picture this pressure essentially squeezing the heart and the great vessels, so the patient can no longer have output. So when we're looking at tension pneumothorax, the big problem is that we start to see increased pressure on the mediastinum, and eventually that is going to lead to increased pressure on the heart and the great vessels, which is going to impair their ability to pump blood forward. So things we want to be mindful of in the emphysemic patient is someone who is deteriorating quickly. We start to hear a loss of lung sounds. We start to see things like JVD, hypotension, that would lead asymmetry of the chest wall, which are going to lead us to believe they have potentially a pneumothorax. The other consequence resides around the VQ of less than 1. So if I can't exchange gases properly, what's going to happen is I'm going to have a buildup of CO2. And that's one of the big problems with these obstructive diseases, is that the patient is going to retain carbon dioxide. The problem with retaining carbon dioxide is there's a couple of things wrong with it. So first, we know that carbon dioxide is a vasodilator. So one of the things that can happen with an increase in carbon dioxide is we can start to see an increased edema in the brain. So an increase in carbon dioxide can actually impact vasodilation in the brain and can lead to some degree of cerebral edema. So one of the consequences of having this increase in CO2 that patients have with respiratory acidosis is that we can see some vasodilation in the vessels that are supplying the brain, and we can get some cerebral edema. So as CO2 levels go up, so one of the consequences of emphysema is going to be an increase in end-tidal CO2, or an increase in carbon dioxide levels, or PaCO2, which can lead to cerebral vasodilation and cerebral edema. One of the other problems is that as we have an increase in carbon dioxide, we're going to shift our bicarbonate buffer system to the right, and we're going to produce a lot of hydrogen ions. So we start to see acids being produced, and we typically are seeing a stronger acid than base being produced, which can cause some consequences. If we look at our normal cell, so if this is our cell here, we have potassium, which is a positively charged ion that lives inside the cell. And we have, in this case, when the patient has respiratory acidosis, they're starting to see a buildup of hydrogen ions outside the cell. The consequence of this is that one of the buffer systems that we have in place is we can exchange hydrogen ions for potassium ions in an attempt to buffer. So what happens, or what can happen in respiratory acidosis when we start to see this big increase in hydrogen ions, is we start to move a lot of hydrogen ions inside of our cells. We know one of the consequences of moving hydrogen ions inside the cell is going to be a decrease in pH, which can have negative consequences on the proteins within our cells. So this exchange leads to more hydrogen inside the cell and more potassium outside the cell. So there are a couple of consequences to this that can lead to a life threat for a patient. One is that our intracellular pH is going to fall. So you start to see a decrease in your intracellular pH, which means that we'll start to see protein denaturation. The problem with protein denaturation in something like the brain is that our cerebral functions will stop working or can stop working. So we have a decrease in intracellular pH, which is going to lead to protein denaturation. And one of the big consequences of this is we start to see a decrease in cerebral functions, especially our vegetative functions. So the patient can lose the ability to control their vegetative functions. One of the other consequences of this is we can see a decrease in myocardial contractility. So this increase in hydrogen ions actually impact the ability to use calcium within the heart cells, and we can start to see a decrease in our myocardial contractility, which is going to impact our cardiac output. So we have a patient who's already retaining CO2, is severely acidosis, and now we're potentially putting them into a shock state by decreasing their myocardial contractility. The other thing that we can see with that exchange is the patient can develop a hyperkalemia, which can further reduce their cellular function. So hyperkalemia can see a decrease in cellular function. So altogether, one of the big consequences of respiratory acidosis is the patient will decrease, or we'll start to see a decrease in cellular function, and the patient can enter a vegetative state. So we can actually see a loss of CNS function. The final thing that we want to talk about is the issue with the VQ mismatch. So if we draw in our heart, we have to think about the fact that this patient, especially when they start to develop a number of blebs and bullae, or they have extensive air trapping and are unable to compensate, one of the risks involved is that we're going to see extensive hypoxic vasoconstriction. So if this is our pulmonary artery that is going towards our lungs, and we know it's going to branch off into the small capillaries in order to provide CO2 and have gas exchange, one of the things that happens when we have a loss of gas exchange, so again, picture all these alveoli that are collapsed, hyperinflated, and they have very little gas exchange occurring. What you start to see when you have that is the body will start shutting down blood flow to those areas. So what we're seeing here, the big characteristic of these alveoli, is they're not good gas exchange units. So because of the air trapping and the hyperinflation, these all have poor gas exchange, or they have a VQ of less than 1. The issue with that is that when we have poor gas exchange in areas of our lungs, what we'll start to see is hypoxic vasoconstriction of the pulmonary capillaries, or the areas that are not receiving as much oxygen as they would like will attempt to vasoconstrict in order to shunt blood to areas that are working. Well, if we think about this patient's lung, a lot of it is not working. So what ends up happening is you have extensive vasoconstriction within the pulmonary vessels. So we end up seeing a high amount of vasoconstriction within the pulmonary vessels, which is going to lead to higher pressures that the right ventricle has to pump against. So one of the things that this patient is at, again, a really high risk of is this VQ mismatch can lead to an increase in hypoxic vasoconstriction in the pulmonary vessels, which is going to increase the right ventricular afterload. So if pressure is really high here, so we have this really big increase in pressure in the pulmonary vessels, the right ventricle is now trying to push against really high pressure, where we start to see an increase in right ventricular afterload. This is why a lot of these patients will eventually end up with right ventricular failure. So typically what happens is we start to see the right ventricle begins to hypertrophy, and over time, we won't be able to supply the oxygen necessary for that tissue, and it will eventually begin to dilate. So we actually start to see failure of the right ventricle, or the right ventricle starts to die off. So we either get this really kind of tiny dilated vessel, or you have a vessel that's experiencing kind of this big hypertrophy. So either a tiny vessel with poor contractility, or a big, thick, stiff ventricle that is having a hard time accepting blood. In either case, we start to see congestion behind the right ventricle. So this is where the patient is at risk of congestion behind the right ventricle, and we start to see signs of heart failure. So this patient can end up in congestive heart failure. Or cor pulmonale, which is this heart failure, right ventricular failure as the result of high pressures in the pulmonary system due to a VQ of less than 1. So those are some of the major life threats associated with emphysema, and that's why we see some of the signs and symptoms we see in this patient presentation.